Go ahead and call the
Yes,
roll.
I'll start with you, Commissioner Guillermo,
Present.
Commissioner Green,
Present.
and Commissioner Chow.
Present.
Thank you. And I believe
Okay.
Commissioner Guillermo is going to read the land acknowledgement.
Yes, and I'm excited because it's the first time I get to do it officially. So let me go ahead and get started with this. The San Francisco Health Commission acknowledges that we are on the unceded and ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Excellent.
Thank you, Commissioner. Would you like me to call the items, or would you like to call the items?
Yes, go ahead and please do that, Mark.
Okay,
That would
sure.
be
Item 2 is the approval of the August 10th, 2021 JCC minutes, and Commissioner Chow pointed out that I inherently left off Dr. Horton from the staff list. So please, when you're thinking about approving the minutes, know that I will amend the minutes with adding Dr. Horton to the final version.
So
Okay.
move the minutes with that addition.
Is there a second? Oh, Dr. Green's on mute.
Was that a second? Yes. Great. I'll do a roll call. I'll start with you, Commissioner Green.
Yes.
Okay. Commissioner Chow
Yes.
and Commissioner Guillermo.
Yes.
Wonderful. Thank you. Item 3 is general public comment. And we've got several folks on the line. I'm not sure if they're staff or if they're folks who want to make comment, but if you'd like to make comment on something that's not on the agenda, this is the time to do it. Please press *3 to raise your hand. *3. All right, I don't see any hands. So but we can move forward with item 4, which is the executive team report. Mr. Phillips.
Okay, Mr. Phillips, thank you.
Thank you. Thank you. Good afternoon, commissioners. Good afternoon, Mark. Thank you all for joining us this afternoon, and our apologies for the brief technical difficulties. Hopefully, going forward, we will get those worked out. So I'll go ahead and jump to, if we can, to slide number 4. I'll give you a quick update regarding our COVID-19 case check-in. So our COVID response continues to be a priority here at Laguna Honda, of course. We experienced a surge in staff cases during the last 2 months, but fortunately, we've had no resident cases since the month of January. Thus far, during the pandemic, we've experienced a total of 277 positive cases, which includes 214 staff cases and 63 resident cases. Currently, we have 5 active staff cases. Next slide, please. As you can see, the surge was really in full effect during the months of July and August. The staff cases were distributed pretty widely across multiple departments here at the hospital. Fortunately, though, we were able to manage these cases very effectively and prevent infections from spreading among our residents. Cases appear to be on the decline as we've experienced 0 staff cases thus far during the month of September. Next slide. Laguna Honda's COVID response has proven to be very effective during the pandemic. The real key to our success has been rapidly responding to changing circumstances and incorporating lessons learned along the way. Comprehensive testing and contact tracing have been our hallmarks during the pandemic. This has really provided us the flexibility to limit movement on quarantine units while continuing visitation and other activities on units that were not affected. Minimizing exposure to the virus while providing a reasonable freedom of movement for our residents has been a challenge, but the results have been very, very promising for us. Slide. Laguna Honda recently started administering a third dose of the vaccine to immunocompromised individuals, both on the resident and staff side. Thus far, 23 residents and 135 staff members have received the third dose. And also, it's been approximately 8 months since the majority of our staff and residents have received their second dose. So we are really excited and hopefully gearing up for wide distribution of a third dose as soon as we get the green light to do so. Next slide. Here's a snapshot of our resident vaccination status. As you can see, we're at 93% resident fully vaccinated, which is great, and only 44 thus far have declined receiving the vaccine. On our staff vaccination rate is very similar. We don't have a slide for that this month due to some data crunching and expanding this particular dashboard, but we'll have it going forward. But the results are similar. We're currently at 91% of our staff being fully vaccinated. Next slide. Here's a look at our admissions, discharges, and expirations. Our admissions have ticked up slightly during the past year, but we're still limited in our by the impacts of COVID-19. So we're purposely not filling the hospital to the full capacity. During this period, we've averaged about 13.6 admissions per month, and we had 17 in August, and we've averaged 8.8 expirations during the period, and we had 14 during the month of August. Next slide. So for this month, we have an employee of the month versus a department of the month. And our employee of the month for the month of August is our admissions and eligibility supervisor, Cecilia Aguirre. Cecilia has been a DPH employee since the year 2000. She's been part of the Laguna Honda team for the past 7 years. Cecilia really is a great leader and an excellent representative here at Laguna Honda. And because she was nominated by her own team, I know that this award really is going to mean a great deal to her. And so congratulations to Cecilia. Next slide. I just want to give a quick update, and Monica can feel free to chime in if she so desires. But we recently, so Monica, as you know, is our CNO, and she's been very busy restructuring the nursing department since her arrival here, and basically rounding out her team. And she's made several key leadership changes during this process. Her most recent change involves promoting Igor Makoro to nursing director. Igor has over 15 years of experience in which he's bringing to his new role. And he most recently served as a nurse manager here at Laguna Honda. Igor really is an impressive individual, and he's exactly the type of leader that we need here at Laguna Honda. I noticed him early on in my tenure after arriving, and his leadership potential was really quite evident to me at that time. So it's really no surprise to me that Monica decided to promote him into this very important role here. In his new capacity, Igor will oversee our positive care and palliative care units, and most likely he will probably have additional responsibilities that he will take on in the future. Next slide. So just a quick equity and culture update. So as you know, our equity and culture initiative continues to be an organizational priority for us here at Laguna Honda. We had a minor setback during the month of August when our department director, Ami Fishman, was redeployed in response to the surge. And that was a big blow to the team because Army was really just beginning to gain some traction after having been previously deployed. But nonetheless, we're still managing to keep things moving forward with the assistance of our assistant administrator, Jennifer Carton-Wade. But fortunately, AMI is also remaining heavily involved despite being deployed. The current work that we're doing consists of continuing to build our infrastructure through training and education. This includes ensuring that Laguna Honda is well prepared for the upcoming DPH Racial Equity Champions Program. We anticipate having at least 10 members from Laguna Honda to participate in this program. We also will continue our participation in the DPH Anti-Racism Fellowship Program. We currently have 10 fellows participating in this cycle, and we are looking to have a similar participation rate going forward. Next slide. Also continuing on equity, another important element of this initiative was the establishment of our Equity Council. We established the council back in April of this year, and we sought to get representation from every department in the hospital. And I think probably at this point, we're probably at about 90% participation on the hospital. We're currently sitting at 40 members on the council. After the council was solidified, we established 4 working groups to spearhead efforts in the areas of data analysis, communications, training and education, and staff engagement. And we had kickoff meetings for those working groups that took place also during the month of August. And with that, I will pause here and try to answer any questions before handing over to Naz for our regulatory.
Okay, thank you, Michael. And I know that there were a few questions that were asked and then answered written by email. And so want to ask at this time if there's any follow-up questions from members of the committee to those questions or anything else in the report.
I see Commissioner Green's hand, Commissioner Guillermo.
I see that. Okay.
Well, I just wanted to thank you for these really thoughtful and extensive responses to the questions. And I mean, feel free to incorporate them in your presentation, by all means. But this was really extremely helpful and really fills out a lot of the interesting questions. I guess the only one from what you've discussed so far that I'd be curious about is this whole issue of individuals who are asymptomatic and are testing positive. You had very few in the recent past. I had a chance to look at the table, but as it relates to not unknowingly spreading COVID to the residents, do you feel that the testing that you're doing is giving you enough of a head start that you would be able to immediately isolate those employees who might be asymptomatic shedders and not so much worry? I mean, the proof's obviously in the September numbers, which are great, but do you have confidence that this protocol will yield the same results for the subsequent months, especially if there is a winter flare?
Yeah, I think so. And team members, feel free to comment as well. One of the, as I mentioned during my presentation, one of our hallmarks really has been our testing effort. And, we've modified that testing effort depending on changing circumstances. And obviously one of the circumstances that changed recently was the fourth surge. And so we migrated to testing our staff twice a week. And that's been really helpful to us in terms of identifying cases early, and so far it's proven effective for us. Obviously, there are we're not perfect. We're not probably at 100% in terms of being able to prevent all cases, but just based on our history and then based on our ability to change our practices, on a moment's notice, has really been effective for us.
But just out of curiosity, what's the turnaround time from the time you actually do the test to the time you grab the result? Is it one of the immediate ones or?
Yeah, it is for the staff testing. Now we're doing the Binex Now test, and the results are available in virtually 15 minutes. So that's been very helpful.
And the false negative on that, do you know the false negative rate on that?
I don't myself, but I know Lisa may be on the call. Lisa may be able to speak to that.
I know
Right,
the
thank you.
false
It's
positives.
fairly low that I recall. It's in the 1% to 2% range. It's pretty low.
Can't hear you guys
And
too
that
well.
is consistent with what we've seen here.
Okay.
I think she said 1 to 2%.
Mhm, I think so.
Yes, that's what she said.
Thank you, Dr. Hu.
Great. Yeah, thanks.
Yeah.
Thanks.
I see
Can I add
Dr.
something to
Alice
what
hand-
Michael has said?
Oh, go ahead, Wilma.
Yeah, so you've mentioned that we do testing for the staff twice a week, but we also do testing for the residents, right? So we do test the residents still every 2 weeks. And so those tests takes about 24 to 36 hours turnaround time. But that allows us to really get the overall picture of what the hospital is doing. So not just the staff, but also what's happening on the floors with the residents.
Thank you, Dr. Hathaway. And Dr. Chow, you had a question.
Yes, thank you for the table that you had so thoroughly displayed. And so I'm wondering on the table that had the column about hospital acquired, each of the months you had 2 staff that had acquired it at the hospital. So what was determined to say that it came from the hospital because no residents were they working within the same unit? And if you're tracing it back to units, it looks like it has not spread to our residents, which is thankful. But would it be that the 2 were working together, or they're independent? What classifies them in hospital acquired?
I think the ones that are listed as hospital actually from contact with some coworkers that ultimately trace back to community. Most of ours could be traced back to community acquired as the incidence of infection spread in the community. Of course, we're vulnerable to live our lives. So that's how it did not come from the residents. Thankfully, I'm knocking on what I hope is genuine wood, that there were the residents had their business contact was really in the context of coworkers.
You know, you're a little far from the microphone. I didn't really hear the entire explanation, but
Sorry about that. Is that better, Dr. Chow?
yeah, I
Is that
did.
better?
Now that's better. Yes, just
Okay,
quite
thank-
curious about how, and are these individuals or were they together or something?
The root infection were usually people community acquired, and they may have been asymptomatic, found later with our testing, but in the meantime, they had had contact with their coworkers here.
Oh,
So we fortunately had no residents, and I'm knocking on wood, that had been exposed. We had caught the staff cases fairly early, but the contact was, when it said hospital acquired, it was really coworker spread from a community exposure.
no, that's fine. That's what I was just trying to clarify. You trace back to a community, and then here was a contact that probably got it from the community contact. Okay, no, that's great. Thank you. Very helpful. Really appreciate that, and the good work you're all doing in maintaining the residency level. I'm still hearing that there are still outbreaks within skilled nursing facilities in spite of the vaccination. So really, Laguna is, you know, a model here, I think, amongst the 700 residents we have. So are you continuing to work with the CDC at this point in time? And are they, you know, looking that their suggestions seem to be quite effective in nursing homes.
So I don't know if Wilmy or Lisa want to address this, but before you do, ladies, I will say that early on during the pandemic, as you all know, we were working very closely with the CDC, and they were instrumental in helping us to shape our protocols and to provide advice and consultation. And after some time, they left the organization, went back to their day jobs. And so we have not been in constant contact with CDC other than to say any updates that are shared with healthcare organizations. We get those updates and we implement, based on whatever guidance they're providing us. But other than that, I'm not aware of any other more direct communication that we've had with the CDC. Team, any other comments there?
No, I think you said it right, Michael. We haven't worked with CDC for a while. We do take we collaborate with CDPH's guidelines, the ASLs that come out regularly, as well as directives from our leaders at DPH.
Well, I think that's good. What I was thinking of was that the department has indicated that they have been able to publish their experience with several dozen papers, and whether that is useful. In other words, using CDC guidelines, or whichever guidelines we're using, here is a very effective process that is, in real time with the largest skilled nursing facility in the United States. And I'm just wondering if staff felt, I know it takes a lot of time to write this up and everything, but it just seems that when you're looking from February down to September, we have 0 residents that become infected. The whole idea of, working towards the herd immunity and using safe measures for staff, capturing them as you do right here, keeping your wards, on some sort of modified lockdown or whatever the process you're using, it's clear it is working. And it would seem to be an experience that is worth sharing with others. So I think it might be actually evidence for a paper, but of course that's a lot of work. So, but it is, from a nation standpoint, this is really an outstanding example of how these things, taking consideration of your protocols and how you have diligently applied them along with the vaccine, that it's been a dramatic 9 months. So that was where I was just looking at from a larger standpoint, being able to share the experience with the nation.
Yeah, and I would agree with Dr. Chow that, and I think we last week at the full commission meeting, we mentioned the role that San Francisco could play in really, just informing the larger public about what works based on our own experience and how we could really influence practices. And really sort of project the good news, and place San Francisco sort of in a different role. And certainly what Dr. Chow is talking about is a great example of that. And at some point, when resources are available and the time is right to be able to share that, I think wider than the commission or even just this committee. Is something that we would I think support. Okay. Are there any other questions on the report? I'm glad you were able to provide not just a department or a unit highlight this time and actually celebrate a couple of individuals. And I'm really happy to see the continued just sort of example of leadership that is that is being shared with us in any case, and the recognition of that, Monica, that you are providing to your staff and highlighting. So thanks for that.
Commissioner, may I check the public comment line?
Sure.
So folks on the line, if you'd like to make a comment on item 4, please press *3 to be recognized. *3. All right, no hands up, Commissioner, so it's okay to move on.
Yes.
Item 5 is the regulatory affairs report.
Thank you, Mark. Good evening, commissioners. Can you hear me okay? Okay, thanks, Mark. Appreciate the thumbs up. I'm going to share with you our regulatory affairs report this evening as my director of regulatory affairs is taking a needed week off. So for the month of August, Laguna Honda had a total of 18 facility reported incidences to CDPH. 2 anonymous complaints were shared with us from CDPH. You have the breakdown in front of you, with the majority of them being allegations of abuse. We had 3 unannounced site visits for the month of August. They reviewed from those 3 visits a total of 40 facility reported incidences. So we can very much see on our end they are playing catch up. I know we've spoken about this a lot here, and so they're now doing their due diligence and coming forward to review those pending facility reported incidences, and we're happy to host them. We had 1 plan of correction that we received on August 23rd, which was standard for one of our prior facility reported incidences, and that, or I apologize, 1 CMS 2567, which we submitted the plan of correction on September 1st. We have not heard any follow-up. Generally, if we have not heard in 2 weeks, we deem that they've accepted our plan of correction. We still have 43 pending facility reported incidences. This is a significant decrease that we have seen over time compared to prior numbers that we have shared with you. And with that, I will pause to see if there's any questions or comments or feedback.
Okay, it looks like Dr. Chow, you have either a question or a comment?
Yeah, I had forwarded a comment wondering what was the subject of the plan of correction. It's pretty broad what it says here, abuse, neglect policy. So was it something specific that we were responding to?
Yeah, so this one actually happened to be an interesting one in which it indicated a gap in our reporting process. So essentially, Laguna Honda did not follow its reporting policy. We did not submit our 5-day letter to CDPH within our 5-day framework. And we shared with CDPH that part of this was staffing changes within QM. We had some interim staff, some training gaps, and so forth. So we've done re-education across the board. But that's what this particular plan of correction was in response to, that we did not submit on time.
Right. Thank you. No, that's fine. Appreciate it.
Of course.
Okay. Any others? Okay. Mark, I think we can move on.
Sure, I'll check the public comment line. Folks on the line, if you'd like to make a comment on item 5, the regulatory affairs report, please press *3. Okay, we can move on to item 6. The presentation is the Laguna Honda Medical Services.
Good afternoon, everyone. Can you guys hear me okay? Okay, great. Okay, next slide, Zoe. All right, so this is our medical department at a glance.
Wait, there's a big square in the middle of the PowerPoint. I'm not
Yeah,
sure if
Zoe,
just
is that on your, there you go. Thanks, Zoe. So this is our medical services organization chart. I'll be focusing particularly on our 4 services that include medicine, outpatient clinic, rehab, as well as psychiatry. And I want to say thank you to Dr. Chow. We'll go ahead and put in your recommendation instead of putting health. It's so tiny in my screen, I apologize. Health commissions, we'll put in JCC for as you had suggested. Next comment. For medicine, Dr. Monica Banchero is our chief of medicine. She's been in her role now for over a decade. She's doing a phenomenal job delegating and directing us into what is needed to be done. And that is to provide care for all residents in all 13. If you want to include the acute unit, that makes 14 units total. We provide both primary care routine visits as well as urgent and emergent visits. Next slide. This is our overview of staffing. In the HR realm, 24.4 FTEs. Our overall, in our terms, is actually 26 providers. That is because we have folks that are both full-time and part-time. If you count me, we will have actually 27 providers. I have continued to see 3 patients on the floor since I took this position. For vacancies, since the beginning of March 2020, when I moved up into my interim role, we have been missing at least a 0.9 FTE, which is 1 head. And then in April 2021, we had 2 positions, 1 retired, 1 quit. And so we are in the process of actually filling those positions. We have 2 new position hires. We hope to start them as early as mid-October. For as needed, we have about 11 providers considered as our night and weekend physicians. We have 3 still open positions to fill, and I'm happy to say that we have hired 2. So we have 1 more open positions, and we constantly are recruiting and constantly interviewing and seeing folks that want to join our team. Next slide. Some of the challenges we faced for the last year, the obvious one is adjusting to changes of the med-op during our COVID pandemic. That includes implementing our admission observation unit, going through resident testing and the constant changes that we had to adjust through the testing of the residents, formulating the COVID unit. Along with that, some of the challenges are the staffing shortages, retirement, leave, vacations, and of course, burnout. A minor challenge, but still impactful, is the loss of our students, residents, and fellows who were unable to rotate since the beginning of the pandemic, which then leads me to my achievements. We are hoping to resume Laguna Honda as one of the training sites for at least the UCSF Family Medicine, Resident Year 2 and Resident Year 3. We also have fellows scheduled for palliative care as well as fellows for addiction medicine. Other achievements, despite the pandemic and COVID, we were able to continue with med-ops with minimal interruptions. There were minimal disruptions with patient flow. We also formulated work groups led by physicians for mitigation and prevention of COVID, PPE use, ethics, and IT. My most favorite achievement of the medicine department is the collaborative effort between the medicine and the psych staff. They have formed this joint medicine psychiatry case, and this started mid-2020, and it's to address the challenging patient cases that affect both departments. It usually starts with a case presentation and then leads into the general topic of discussion. And so far, our discussions have ranged from post-stroke depression, complex trauma, PTSD, personality disorder, and behavioral management challenges. Next slide. Physical medicine and rehab. This service is headed by Dr. Lisa Pasquale. As you all know, we do have acute and SNF rehab residents. In my opinion, actually, that one can argue that all of our residents fall into some form of rehab, but to fall specifically in this category, you have to have certain requirements and criteria, and listed there in bullet points there for you. They must require supervision of nursing 24 hours daily in one of the more following. And most importantly, they must be capable of fully participating with the rehab program and need to be able to demonstrate the ability to progress toward a measurable goal. Next slide, please. For staffing, 1.6 FTEs for us, that means 3 providers. These 3 providers are board certified in PM&R. Along with our PM&R attendings, we also have 1.5 primary care physician equivalent to help with any sort of medicine, complex problems that need assistance. As we all know, we go into certain specialties when we do residency, and we lose skills in the other parts of the medicine world. And so we have the rehab world and we have the medicine world collaborating with each other on our SNF rehab unit as well as our acute rehab unit. PMR also not only sees inpatient for the acute rehab, we have 5 beds, and the SNF rehab, we have 49 beds, but they also have outpatient clinic. They see patients throughout the house. They get referred to them for possibly rehab services. Dr. Pasquale does EMGs in the clinic, and she also does Botox injection in the clinic. Next slide. Challenges for the PMR group. Underutilization of our acute rehab unit. If you've been with Laguna Honda long enough, you know this is an ongoing challenge for us. Reasons range. There's very strict criteria for admission to the acute rehab world. They have to be San Francisco residents. They have to be housed, and most importantly, it's the insurance eligibility component that makes it quite difficult for our to broaden our scope for referrals. We typically don't have any referrals from a private pay insurance. They need prior auth. And if there is a facility that's contracted with a private pay, that's where they end up being referred to. Medicare patients, we can get these referrals. However, patient preference Laguna Honda tend not to be a favorite for them to go to. And so our referral base is typically left with Medi-Cal patients, medical pending patients, as well as undocumented folks. Other challenges as an overall theme is the overall theme for Laguna Honda residents ready to go home is community disposition challenges. There's just not enough housing available to them out there in San Francisco. Goals is obviously to increase census, improve utilization of acute rehab, making sure we meet the documentation standards in EPIC, what we're calling the Inpatient Rehab Facility Patient Assessment Instrument, the mouthful, it's called IRFPI. And then also resuming teaching. We have already started in mid-July, ortho resident year 1 and medical students rotating through Laguna Honda with Dr. Pasquale and her group. Next slide. Psychiatry. Our psychiatry is headed by Dr. Yifang Chen. And her group has about 14 providers, total of 13 FTEs, as stated there. She has 4 psychiatrists, 4 neuropsychologists, 3 licensed social workers, as well as 3 what we're calling healthcare workers that are broken down to STARS counselors and behavioral specialists. Now, she too has several vacancies. We are still vacant 1 psychiatrist, 2 social workers, and 1 healthcare worker. Next slide. Their services can be obtained through e-referrals. They also see urgent and on-call patients that needs to be assessed immediately. They see patients either on the neighborhood or in the clinic, and they provide individual and or group therapies. Their services include mental health, substance use, behavioral health. In addition to that, they also have behavioral risk screening, or what we call BAT, Behavioral Assessment Team. This is a service provided to the admission screening group at Laguna Honda. When we get referrals of patients with backgrounds of mental health, substance use disorder, or behavioral health, we ask Dr. Yifang Chen's team to actually either do a chart review or an in-person screening to see if the patient's needs can be met here at Laguna Honda. And then lastly, we also have the neuropsychological assessment and testing available to our patients here at Laguna. Next slide. Psychiatry services is limited not only to direct patient care, it also includes indirect patient care. This includes support for the resident care team, training and education for staff, as well as participation in PI projects and task forces. Slide. Challenges met by the department, staffing shortages, operations caused by COVID, increased pre-admission screening volume. This was a result from admission screening team actually requesting a thorough assessment on all patients with substance use disorder and mental health. In the past, we have only been selective as to who we would ask that to see, but because of our overwhelming incidences with utilization, with unusual occurrences stemming from challenging behavior from our patients, we thought best that all patients referred with behavioral issues should be screened by that. Some of the achievements from the COVID pandemic, she and her team have formulated the Warm Line, South 5 enhanced support, enhanced individual outreach, as well as participating in our Code Home response. She has increased hiring recruitment efforts, and despite the increased pre-admission screening volume, she was able to manage the increase and able to still offload the assignments to the rest of the team. And then one of the actually greatest achievements psychiatry has done is the establishment of behavioral rounds. Because of the increase in our incidences with behavior challenges, a few of her team members do specifically focus on units with increasing incidences, such as South 5, North 1, South 2, and Sylvania and Mezzanine. Next slide. Lastly, outpatient clinic services. Our chief of service is led by Dr. Christina Lee. There are multiple specialty clinics available to our residents, all done through e-referral. I wish we were all able to see each other because I would take you on a tour to our clinic to show off what our facility looks like. You don't remember quite how it looks like. We do have, we have the dental clinic, we have all the panorama, all the other x-rays that a patient would need to fulfill their visit. We also have optometry and the equipment that is needed for eye exams. So these are just some of the lists of the clinic services that we do provide here at Laguna. The newest one here is the annual exam by Auk Health. We have always had a variation of Auk Health here, but it just includes the PPD and making sure the titers are done for immunization. But this year, Dr. Lee included annual exam for our staff. Next slide. Lastly, challenges met by the outpatient clinic. We had to close clinic at the beginning of pandemic in March 2020. We were able to reopen in September, however, with reduced limited services. The clinic services were decreased during the pandemic overall. But the achievement is we were still able to provide essential services despite the closure. We were very inventive. We used a variation of telehealth. We had actually having some of the consultants go onto the floor instead of having the patients go to the clinic if the service was urgently needed. And then we were able to reopen all but 2 clinics by March 2021. Currently, all have been resumed except for the ENT clinic, but this was not due to COVID, it's due to UCSF contract negotiations. We hope to get this rectified in the next month or so. We're just working on the standard procedures. And then just some stats, the number of patient visits this past fiscal year is about 4,000. Compared to the previous years prior to the pandemic, we had 6,000 visits. For the number of employee visits, we're about 5,500. This is a little bit above our normal average from the past years, only because we did implement the annual health exam clinic as well as providing COVID vaccines here. And that completes my report.
Okay, thank you, Dr. Hathaway. It's really, really nice to be able to get that comprehensive overview of everything that's going on in the department and all of the things that have sort of been a challenge and what you've been able to overcome. Let me see if, and thanks also for answering the questions that have been posed to you again by email and written, but want to see if there's any follow-up questions or comments from the committee. Dr. Chow.
Yes, no, I wanted to thank Dr. Hathaway. Dr. Hathaway, how long have you been here at Laguna?
So I started in 2007, Dr. Chow.
Okay, sure. So I'm trying to think. You might recall, because I'm really struck by the number of services and the organization of the entire medicine department compared to about 20 years ago, where basically it seemed to me that we were doing primary care and it was as needed specialty care, and we didn't have, of course, the clinics. I remember just struggling to even get dental services back over there, and we certainly didn't have this range of outpatient clinic services. I'm just really struck by the increased sophistication of the program, and the fact that many years ago we had said it would be great to integrate with the programs at UCSF, and you've all done that in several of the specialties to make use of our experience here, and also increases the experience for the training programs at UCSF. So it's not only ZSFG, but LHH that becomes a very important part of the UCSF training. So I really wanted to commend you and the entire team there for actually creating this, and it's a far different, seems to me, a very far different and more sophisticated medical service, and of course your psych and the physical therapy services that you've had. So of course there's always an or and the or but the but part, actually, you did address with the acute rehab, and I'm sorry to hear that it might take another year because this has been going on for the last, 10 years since we moved into the new building. And at that time, we had also discussed having a plan of action that would work with the contracted health plans. And now you're bringing that back up again. And I'm just wondering how that actually had either fallen through the cracks or was not successful, because with the brand new facility at that time, and now is still a very superb facility that's as good as I think anything we can find for acute rehab, that this should be something in which those 5 beds are always filled, and you would be fending off people who would like to get into this wonderful facility. So I'm interested, what are the new approaches you're going to be taking that actually would finally get this piece accomplished?
Well, funny you ask, somebody say something?
Maybe I should start, Wilmy, and then you can continue.
Thanks, Michael.
I just wanted to acknowledge, Dr. Chow, that is an excellent question. It really is. And I agree with you 100%. We do have a wonderful acute rehab unit, and we are committed to maximizing our ability to provide those services. And one of the things that we're exploring right now is to become accredited, because if we can achieve accreditation, I think we can utilize that to build the brand and to attract more potentially more health plans, if you will, to entice them to send patients to us. So that's something that we're exploring right now. There is also a contracting effort underway at the network level, and they're including acute rehab in that discussion, and that may drive some patients our way as well. So it's high on our radar, and we definitely will be looking to maximize our potential in this area.
You know, Michael, it just, as you were talking, suddenly reminded me and reminded us that ZSFJ had reported that they had a contract for midwifery at OB with Canopy. And that is a contracted plan that certainly, you know, UCSF and the city has had, well, I should say UCSF has great interest in. And this might be an in to also then looking at contracts. Those people, you have nothing to be ashamed of in your facility. And that might be a lead right there. And maybe you're already exploring that.
We are indeed. It is part of, we have been assured that acute rehab will be included in that contract negotiation.
Oh, good. I don't think we need to belabor the point any further, and I don't want to put Dr. Hathaway in a position which is outside of her scope of responsibility. Thank you very much for your answer.
All right, Dr. Green?
Yeah, well, I would echo what Dr. Chow said about how impressive your breadth of services and the quality of your staff. Those that have come before us are just top-notch individuals. I know a few on the outside, like Lisa Pascal, and just wonderful, dedicated, amazing people. One of the questions I was kind of curious about is the training programs. It looks like you don't have residents that come over in psychiatry, which might be a real, benefit. And I was wondering, just from your perspective, you have some, I think in the rehab, you have year one, PG1 residents. How do you utilize them? I mean, sometimes teaching can really be a drain, and yet I can see ways they could help with things like making sure medical records are complete, or even doing some side projects that might help streamline certain initiatives you have underway. So I'm wondering, is there an individual that's really responsible for the trainees, or is it by the division? And then, what's sort of the balance between, it's always exciting to teach, but what's the balance between, what they can do for us versus what you're doing for them in terms of speed with which you see patients and some of these other things?
So it's been a while since I was a resident, but I do remember when I was a resident, you would go through rotations. So every month has a different rotation. It's very similar to what the residents are doing when they filter through here. For example, the one that rotates through ortho surgery or rehab usually rotates with Dr. Pasquale. And her rotation is, I believe, once a month, and in that month, they're only here for about 2 days. So it's very limited amount of time that they spend here, but it's part of whatever rotation they're doing for the month. I know more of family medicine because that's the one that I'm actually overseeing. So for the family medicine resident group, they have a continuity clinic or continuity of care rotation, or theme. And within that continuity care, they come to Laguna as part of that program, but they're only here half a day a month, which is very limited. And so with that program, what we do is, what we've done in the past is there's a didactic part for about an hour, and then we send them onto the floor, and they're assigned a patient. And in theory, they're supposed to follow that patient throughout the course of their PGY2 and PGY3, all alongside the attending that is essentially the attending for that floor. For the addiction fellow, they are assigned a provider, and I can clarify this with Dr. Chen so that I'm giving you any misinformation. And the palliative care fellow is overseen by Dr. Hayward in the palliative care unit. But it's not a set schedule. It's an elective. Those two are elective rotations. And it's under the purview of the attending what they are assigned to do, whether it's following a patient, participating in the interdisciplinary team meetings. Documentation is really not the focus for us. It's more of having the experience of seeing the patients at Laguna.
So it sounds like it's really, you're really supporting them rather than, just for the, uh, kind of the, relationship with UC and the potential for teaching as opposed to them really being there enough to provide services.
Right, yeah. So at least for the program coordinators for the family practice side, they are very focused on ensuring that their residents experience patient life and patient care. They're not more so teaching them the didactics or, for example, tube feeding, because they get that portion in their class. They want clinic experience, hospital experience.
Thanks. Thank you.
Thank you. And I'm sorry, Mark, I keep forgetting to see whether we have anybody on the line that wants to, any public comment first before opening it up to the commissioners. So
Thanks, Commissioner. That's all right. I can always do it afterwards. Folks on the line, if you'd like to make a comment on item 6, please press *3 to be recognized. *3. No hands, Commissioner.
Okay.
So let's move on to item 7. Thank you, Dr. Hathaway. Item 7 is a presentation, Laguna Honda Hospital 2919 Plan of Correction Dashboard.
Thank you, Mark. So commissioners, this evening I'm sharing with you a plan of correction dashboard, which is a follow-up to the presentation I shared with you back in July. And I apologize, Commissioner Chow, we missed you that evening. During that JCC meeting, I shared a very in-depth review of each of these measures in terms of why they were brought about and what is the work being done for each of the measures presented in response to the events that occurred in 2019. A request that came from that meeting, rightfully so, was more of a visual depiction of the measures and where we have been over the past fiscal year. So this is a breakdown of each plan of corrective action item from the 2019 plan of correction that was submitted in response to the events that occurred. As you know, green means that we met our mark, and red means we fell a little bit short. Just out of respect to not repeat myself, I'm happy to answer questions from the data you see in front of you, or if there's any clarifying questions that there might be. I just want to be mindful of what would be most beneficial to you all, given the presentation that was given prior.
thank you, Naz. Let me first see if there are any general comments.
Sure. Folks on the line, if you'd like to make comment on item 7, please press *3 by raise your hand. *3. No public comments, Commissioner.
Thank you, Mark. And then let's go ahead then with Commissioner Green.
Well, my hand was up from before, but I might as well just thank you for the really thoughtful comments you made about the 2 areas that obviously are in your red zone, the medication simplification, and I think that's a really tough one, as you've identified, and it's great to hear the team is kind of revisiting that. And then, of course, you've already discussed the timely reporting and the nuances of that. So it sounds like the plans of correction are really well developed and enforced. When would you anticipate, given that you're thinking about this, especially the 2 that are right across the board there, when do you think you might see a shift in the outcomes here? And sometimes I realize these outcomes are pretty small numbers when you get down to it, like 3 here, 4 there, and so it's kind of hard.
Yes.
I mean, what do you think? Like what quarter do you think you'll start seeing some either that you institute a change in the medication frequency, or else something else with your reporting?
That's a great question. I think the other thing I want to highlight too, which happens in these moments when we're responding to immediate jeopardy situations, right? We put forward very robust goals that aren't sustainable throughout time, if you will, right? So I think that's some of the things that you see as well. And so I want to acknowledge that these goals are loft, if you will, especially the resident check-in ones, as well as even just the medication observations that our nursing leaders have to do. you know, my hope, at least let me start with the timely reporting one, and then if it's okay, I want to just partner with Wilmy in terms of the medication simplification, because I want to be respectful of the work that medicine is doing. So for the timely reporting, you know, as you highlighted, it's a really small N that we're missing the mark, but it is still impacting our compliance. So on average, it's 3 that we miss. I think the learning that we're seeing, which is causing a potential gap, is that the reporting is on the onus of the individual across departments. The prior kind of format, if you will, which is standard in many facilities, is that the incident gets reported to risk management or quality management, and then quality management reviews and assesses if it's reportable or not. In response to what occurred, we essentially said, well, as DPH employees, we are all mandated reporters, which is true. And so everyone is responsible for reporting. So they no longer have to come through quality, if you will, or leadership to see if it meets the threshold for reporting. Sometimes what happens is they might not know all the processes, or some instances that we've seen is a department will do an intake with a resident. They'll note it in the medical record that they think something reached the threshold, but then nobody reported it because there wasn't a verbal handoff, right? By the time that that note's reviewed, we've missed our 2-hour window. And so quality management has done a lot of one-to-one training and coaching with various disciplines to review the steps that are necessary, ensuring that there's proper handoff, especially with nursing, because our nursing partners do a lot of the investigation work currently that will shift over time. But currently that is part of it as well. And so just as I share with Commissioner Chow, you know, a nurse leader was given improper guidance, which resulted in a deficiency for us because there were gaps in learnings. So again, these are opportunities. My hope in terms of timely reporting is that, you know, as soon as my team is fully built and we're doing our robust trainings outwardly to staff, that we'll see that that mark turns green, if you will.
Is the extent to which, you know, reporting is the forum for reporting, is that a barrier? In other words, some of these things are so time consuming that you just throw up your hands and go. And I've had that myself where I thought, oh, I really need to report this. And then it's like, oh my God, I can't go through another one of these boxes again. How much of that is a barrier, do you feel?
I don't think, at least the feedback I hear from staff, and Monica, if you have different feedback from your team, the feedback I hear from staff, it's not the act of calling CDPH, that's probably the quickest step in the process. The challenge and time consuming portion is the investigation. That is a great deal of work. But that's not what's causing the red in terms of that measure.
Okay, great.
And then Wilmy, do you want to share about med simplification?
Yes, you know, I mean, that whole, I think it really needs to be revisited. The whole metrics and the goals all have to be revised, in my opinion. And I think now that we have a new physician champion, this is the opportunity for us to revisit it. We have yet to meet this goal since we started this project. And so that tells us a lot. It tells us that maybe our metrics are not right. Maybe our goals are not right. It's just definitely something for us to relook at and come up with another plan.
Well, it's quite,
And so,
it's quite admirable that you have stretch
unfortunately,
goals too. You know, these are really
what was that? I'm sorry?
it's really admirable that you have stretch goals, and many of these are indeed stretch goals. So,
Right, and it's okay to have stretch goals. You know, we want to overachieve and underachieve, but there comes a time where we have to say, okay, we need to revisit and look at it over again. So, you know, I'm looking forward to see what the new group comes up with. You know, I think when this was first initiated, it was a, you know, it was like a gunshot fire. You know, it's just a first attempt. And I think now that we have a little bit more data, a little bit more, newer, fresher input, I think we'll come up with something a little bit better.
right.
Oh, Commissioner Guillermo, you're on mute.
Thank you. It is something that comes up and that we note, you know, at every meeting. So I do think that, you know, now that it's been, you know, a year plus, you know, you have enough data and experience to be able to sort of take another look at that. So, yeah. Okay.
Yes,
I believe-
absolutely. And I think the next step for us really is to, as Wilmy highlighted, how do we adjust to make it sustainable and also outside of the plan of correction, if you will, right? There are items in here that are good, that should be part of our day-to-day work, and we want to start to message it as such, right? And review it in terms of how are we meeting the mark in terms of expectations that are put upon us for our day-to-day work outside of these corrective actions, and provide it a new narrative. Because I do think that there's something to be said when you are continuously communicating an effort that's related to something that has a negative onus. There's a different response. And so if we can change our communication approach and sharing with our staff that this is part of our scope, these are our new expectations and our direction, I think sometimes that also helps with folks being more excited and in line with the work that we're asking as well. If that makes sense, what I'm sharing.
Thank you. Dr. Chow, you had questions.
Yes, I had actually a observation or two, but following your statement just now, any changes in the POC, what will that actually do at the state level? And how is the state actually monitoring whether or not we're doing anything?
That's a great question. So to that point, theoretically, Laguna Honda has actually already been found in compliance with these corrective actions, right? So when CDPH conducted their 2 on-site visits back in 2019, as you will recall, in September and October, after the second revisit, we were found to be in compliance with all our corrective actions. We as a team continued these efforts just because we recognize and appreciate the weight of the incidents that have occurred. And I think now we are in a position with new leadership among our executive staff and new visions and frameworks that we are all hoping to instill and implement. We're ready to make that shift. So from the CDPH perspective, Laguna has checked the box, if you will. So now I think it's our duty to do our work for sustainability.
Okay, that makes a lot of sense. So the other thing I just observed here, understanding that some of the goals you're going to be rethinking in terms of practicality and how to achieve the outcome, because medication observation, of course, was related to several issues, right, including controls and then also the idea of check-ins, or I guess on the resident level also to make sure that we weren't getting a lot of drugs coming in from the outside, which then required that there be, or the corrective action there was to try to check in with the patient when they came in, right?
Yes.
So I see that, of course, you're correct. We need to try to then continue to be sure that anything we're doing is not going to go backwards and allow those bad habits to occur again. So
Correct.
I'm a little concerned that you were doing very well, for example, on resident check-in. And of course, some of that is because in COVID, very few people went outside. But it does show that you were looking at a certain number, and they were achieving very high levels, and then it begins to drop over several months. So it would so whatever happened there, and that also sort of looks at of course the out and pass. We don't really have much history, but you've got a history in which 91% of assessment in the EPIC was performed, but the following month that dropped to 79. And I think that's probably one of those things that are important, right? That you're saying, okay, how can I make sure that my residents coming back are clean, so to speak, right? as much as we can within the limits of privacy and all. And that was the whole idea of trying to set these up, right? One was, of course, the medication problem, and the other one was drugs coming in that we didn't even know about. And these were, you know, areas we thought we could kind of control with this. But if I see that it looks like even on measures are declining from where we were, the reds are artificial because that's you setting the benchmark. But it does say less people are doing something that was really important. So what are you feeling? And I guess are you feeling that we're still, you know, the ultimate question is, are we still feeling that we are safe and doing everything to avoid the issues that arose out of the 2019?
That's a great question. And I do want to ask Monica just to speak to her nursing team and their capacity and workloads. I want to acknowledge that, you know, part of these fluctuations that we see in percents have to do in terms of other competing factors, right? For instance, sometimes we'll see that there will be changes in our numbers depending on COVID cases that we're experiencing at the time or other issues. I think that to your great question about, you know, does it feel safe now, right? Does it feel that such things could happen again? I can only share with you my opinion, right? Is that yes, for me, it feels safe. I think that we have a lot of new measures in place. I think we've learned a lot over the past 2 years. I think that the new leadership you have before you are determined and have this as a priority that we discuss weekly and how to ensure the safety of our residents and staff. And I think we've learned how to use Epic to continue to learn, but are using it to be the best tool that it can be to support us in these practices that we didn't have before. I'll just pause there and let Monica share because I know her team works really diligently on these items.
Thank you, Naz. I agree with everything you said. So what I will add, Commissioner Chow, is specifically to your questions around resident check-in. So that is the staff, any member of the staff team checking in with the residents. So that is every single resident on every unit needs to have a weekly check-in. And what that looks like is that any member of the staff, it could be nursing, it could be social work, it could be activities therapy, they're specifically checking in with the residents. So with that being said, there were some challenges with actually doing the audits, not necessarily the check-in that didn't happen, but actually auditing, because this is a manual paper process. So the nurse managers actually have to manually keep track of how many check-ins are done. And we are very hopeful that as Naz brings on her team, she's brought on a couple of people already who have provided these wonderful dashboards and this wonderful data, that we will get automated processes so they do not have to manually do this work. It is very difficult if you look at the numbers, and I'm just going to be totally transparent, and Naz and I talk about this all the time. I've never seen audits with thousands and thousands of audits, and I've worked in a lot of environments. So they're doing an extraordinarily amount of audits, and to have to do it manually is very challenging. So it doesn't necessarily mean that it wasn't done. It means that it didn't get put on the piece of paper that got collected. So I hope that makes sense as part of it. The other piece of this is if you look at the resident check-ins and you look at the months prior to May and June, it was green across the board. And I will say that it was green across the board prior to this actual dashboard. So traditionally, when you have consistent performance, these type of audits get retired. You know, you show that you have actually, I see Dr. Chow shaking his head, you show that you've actually completed the work and the audits are retired. So from my perspective, this audit in particular should have been retired a long time ago. And we gave our staff, in all honesty, a lot of wrong misinformation the last couple months. We told them they could stop doing it this way, they can do it differently, and then we had to come back and tell them we are going to continue to manually do this until we come up with a better process. So that provided some challenges for them as well. But I will say one of the things that I shared with you all when I did my presentation is the idea of hourly rounding, and I know you all had some thoughts about that, but we are going to implement that at Laguna Honda, and we are going to have a meeting in a couple of weeks to talk about how we're going to pilot that on a couple of our units. So if you're doing hourly rounding and not at night, Commissioner Chow, I know you were concerned about waking people up in the middle of the night. So we're going to work through that a little bit to see how we're going to effectively be able to do that. But there's been a lot of studies from Studer in particular about hourly rounding and post-acute. Although it's a new concept, it's being done. So I think this is going to help with a lot of the audits that we do and our processes. And it goes back to what Wilmy was saying about relooking at the way we're doing things and refining it, especially when there's challenges around meeting these goals. And that's really what IHI recommends. If you're not meeting the goals, you really need to relook at the goals and then determine what systems factors are contributing to not meeting the goals, not just the people factor. And I think we're working on that. So hopefully that answered your question, Dr. Chow, in regards to that.
No, it certainly does, and I think the dashboard was extremely helpful to understand
Yes.
the full scope of work that we were putting in place, say we, because we were all part of that,
Mhm.
to agree that these were the beginning steps of trying to avoid the problems again of the past. It sounds like, I think it seems very reasonable to rethink, are there different ways of doing this? We tried our best with these efforts, and I think the medication example is very good, saying that you don't need to do that, and perhaps we don't need 100% of audit. You're quite right. That's not really the sampling, right? We normally do run things by samples or by aliquots in order to then make an assumption going back. So when we set ourselves up to 100%, that really is a challenge, and I think you've described very well the challenge to a staff, and really appreciate your sensitivity to that, and the fact that we'll be seeing a change dashboard, I'm sure, which I think would be one that has been well thought out again to prevent the problems of the past. So
Thank you.
Okay, I don't, excuse me, I don't see any additional hands, but thanks. I think this was a really good presentation and discussion of the dashboard. And really, again, my only comment is, when you think about what we've gone through over the last year and a half, and even prior to that, with the challenges that we had, to see the progress that we've made in capturing data and being really upfront about discussing the challenges around that, I really just have to give a lot of credit to the new leadership that that is really, I think what I'm seeing is a really great sort of leadership within the team and together, coming up, taking responsibility for each other's areas, and not just saying that's somebody else's domain. And so that does bode well, I think, for continuing excellence in best practices, and really catching any challenges early enough so that we can do prevention and problem solving, as opposed to having to catch up with solutions that on issues that we might not have been able to address in advance. So let's, Mark, if we want to go ahead and.
Yes, of course. Item 8 is Laguna Honda Hospital Quality Management Presentation.
Good evening. I apologize. I feel that I'm speaking a lot tonight. I turned off my video to take a water break. So I'm very excited about this presentation. I wish you were all here. I know we'd hoped we'd be in person for this month, but hopefully soon enough. But I wanted to take some time this evening just to share with you an update on the restructuring of the quality management team. It's a perfect segue from what we were just discussing. This is a big part of the work that we've been doing for the past 2 years. I will provide this presentation in partnership with Troy. So tonight we'll do an overview of what quality management centralization looks like at the San Francisco Health Network. And then I'll dive down into what it specifically looks like here at Laguna Honda Hospital. Next slide. And so I will pass it to Troy for about the next 5 to 6 slides. He'll provide to you the overview of the San Francisco Health Network Quality Management Centralization process. And then I'll go ahead and do the deep dive. Troy?
Good evening, commissioners. Good evening, Mark. How are you? See everybody. Thank you, Naz. I really appreciate the opportunity to provide a high-level overview of network quality centralization, really specifically as it relates to Laguna Honda and the fantastic work that's happening, which, as Naz said, is really great timing after our last discussion. Next slide. So, no, I'm sorry, slide before. So this was the original A3 that we used to really set the path for quality centralization. Of note, this A3 was written back in January of 2020, and then the COVID pandemic occurred. From that point on, I was deployed, multiple deployments, both as incident commander at Laguna Honda and then at Moscone Center for DPH. And so a lot of this work was put on hold during the height of the pandemic. Next slide, please. When I returned in February, this is the A3SR, and this is really the opportunity for us to take a look at, even though the pandemic was, really at its height, there was a lot of work that was continuing to move forward as it related to quality centralization and really the building of the Laguna Honda program, which Naz is going to talk much more about. So, we're going to talk about some of, these things in the next few slides that are really high level, but, I would be remiss if I didn't, really give some heartfelt gratitude to Naz, to Adrian, to Leslie Savior, to Claire Horton, who really kept this train rolling, during the deployments and made it much easier for me when I came back to really dig into this work. So I really, really appreciate all the work that everybody put into this. Next slide, please. So I wanted to, again, bring us back just a quick timeline around the quality management centralization initiative, if you will. Go ahead and click. There's some animation that will come here. So if you'll recall, back in March of 2019, I was deployed and Adrian Smith from ZSFG to Laguna Honda to conduct a quality assessment and assist with the investigation and regulatory compliance related to the abuse events of Laguna Honda. Next click. Should be another circle coming up. There we go. Laguna Honda was placed on immediate jeopardy in July of 2019 related to those events. Next click. And part of this work that we're talking about today was really in this Laguna Honda turnaround plan. As you will all recall, this was something that was presented here to this group, to the Board of Supervisors, the mayor, and others around the specific plans that we were going to, really go through to make sure that things that happened at Laguna Honda could not happen again. Next click. So Laguna Honda was put back in compliance with federal and state regulations in October of 2019, which was a very big accomplishment with the 2567 that had been provided. It was a really big win for this organization at that point. Next click. So from that, in January of 2020, the Health Network Chief Quality Officer, my role in the Director of Population Health Management and Quality for Ambulatory Care was appointed, and that's Ellen Chen. Next click. Fantastic new CEO of Laguna Honda was hired in April of 2020, again, really starting to build this leadership team, Michael Phillips. This is an important piece, and we'll talk a little bit more about it in a couple slides or in the next slide. The SFHN quality centralization budget was approved by the mayor in October of 2020, and that's really important because at that time, everything was really focused on COVID. And so, really thankful to the Health Commission and to the mayor and DPH leadership about getting this very critical budget approved that is really helping us to build this Laguna Honda program. Naz, our Laguna Honda, our inaugural Chief Quality Officer for Laguna Honda, was hired in October of 2020, which is fantastic. Next clip. The ZSFG CQO was hired in May of 2021. That's Adrian Smith. So the leadership team really started to come together for centralization. And how we're looking at centralization right now is really a phased approach. Phase one is really the centralization of ZSFG and the Laguna Honda programs. And so that's where the majority of the focus is going to be for today. And then next click, phase two is really looking at the rest of the network, and that assessment will begin late this year, early next year. Next slide. So this is an important slide, and I don't know that you've seen this before. I don't remember presenting this, but this was when we came over in 2019. This is what quality looked like at Laguna Honda. In fact, the quality management department was actually known as the utilization management department, and quality was a part of the department. So again, you can see the number of quality FTEs that were assigned to Laguna Honda. There was really no centralized structure, as you can see. The RNs did no quality work. And so you really had risk management, regulatory affairs, combined RNs. So quite a bit of role clarity issues there about who was responsible for what. And I think the other thing that you'll notice here is there really isn't that proactive performance improvement arm like you see at ZSFG, Leslie Sapier's team. And so, to me, with the size of this organization and the complexity of this organization, it was critical that we were able to get that budget approved and start to bring in quality professionals, experts, if you will, to really help drive this program. Next slide. So this is what centralization looks like now between Laguna Honda and ZSFG. You can see a much more centralized approach with the needed resources at Laguna Honda, and it very much looks a lot like what we have from a structural perspective at ZSFG. You'll see now at Laguna Honda, you'll have the performance improvement arm, and Naz will talk much more about that in her presentation. But now we have less role clarity issues, right? We have a risk management department, a new director of risk management. We have a regulatory affairs department, and the patient safety RN, once we're able to get that person hired, will now report directly into quality, where in the previous model reported up into nursing. And so the other thing to note here, which is different, go back just one more piece, thank you, is we are centralizing here infection prevention and control. This was something that was very important that really became critical during COVID, where strategy, best practice, is really going to be centralized with infection prevention and control, and we'll cover both Laguna Honda and ZSFG, and we're currently in the process of recruiting for that role. Next slide, please. So that's the people piece, but I think the important part of this as well, since over the last year and a half, is it's not just the people, but it's aligning best practice, resources, and standard work. And there's some examples there which I think are important to highlight. Shared resources. I mean, one big shared resource was the COVID response. I think that was a huge opportunity that we took advantage of. I think that showing how the quality departments at Laguna and ZSFG can work together was very impactful. You can see some other examples there on shared resources. The other thing is processes, and I think this group will appreciate. You've started to see over the last year some of the standardization pieces that we put in place. So, for example, the JCC regulatory report, the PIPS template in minutes. the RCA process, the Sentinel event policy. These are things now that we've standardized across campuses. So for like Dr. Chow and Dr. Green, this is what you see when you're in the JCC and CSMG. And so really trying to standardize that. I know, Dr. Chow, you've been asking for that for many years, and so we're finally getting that in place. So that's great. A couple other things just to highlight before I turn it over to Naz. QM staff huddles. They've standardized that between the two quality departments. There's the last thing I'll highlight is working with WILME around the PIPS policy, the med staff bylaws, and the governing body bylaws to standardize as much as we can for alignment between the two organizations. And so there's a lot of exciting work happening. And with that, I just can't say enough about the leadership that Naz has brought as the, again, inaugural Chief Quality Officer here at Laguna Honda. And I'll turn it over to Naz to tell you about all the exciting work that they're doing in building this department. Thank you.
Thank you so much, Troy. So yes, I'm going to dive into the work we're doing here specifically on site at Laguna Honda Hospital and the rebuilding and restructuring. This slide in front of you is one back, Zoe, please. Thank you. This is the strategic A3 that I put together, and I really want to share this with you because I think it's so important to note that the restructuring and rebuilding of this team is rooted in A3 thinking. And why that's important is A3 is grounded in a collaborative process, meaning that I reviewed this with the team here. I got their feedback and input so that we can problem solve and improve together. And the gaps and challenges that we identified as a team that we'll talk about moving forward, and some of which Troy already highlighted in the centralization process, is the inadequate staffing model that the QM team used to have. The lack of standard training and opportunities for professional development. This was a huge gap for the team here. And a lack of data governance and data availability, which we already touched on a bit as well. And so being able to review these opportunities gives us the avenue to begin setting priorities and setting our action items moving forward. Next slide. So this here is our framework in which we are restructuring our department. And so the framework that we are building is built in a process improvement world, in a way that we can improve the delivery systems, the care delivered to our residents at the front line. The goal of the department is to support and guide discussions of improvement across all disciplines, especially in collaboration and partnership with medicine and nursing. Additionally, the QM team is wanting to engage frontline staff and also set directions for improvement and supporting a learning environment as well. I think that's a big shift that I want to highlight, that we really want to provide a customer service to our staff here and support discussions and learning together. Next slide, please. So these are our 4 priorities for the department. This is very much in line with the San Francisco Health Network quality management priorities as well. So our department is focused on building the department, right, which is through the recruitment and hiring of staff, and also through professional development. In my short tenure, which I can't believe it will actually almost be a year, how quickly time goes by since I've been onboarded, I have really promoted and created space for professional development. It's extremely important to me that staff have the tools and skills and also just confidence to do their day-to-day work. And a lot of that comes from the opportunity to participate in trainings. And so our Director of Regulatory Affairs has already participated in a certification program with Harvard. Our Director of Performance Improvement has self-nominated for the Emerging Leaders Program. And our Director of Risk Management is participating in the 24-hour plus training provided by DHR for managers in the city. And so it's so great to see that the new leadership team here also feels it's important for them to make that time. Our second priority is really to ensure that we're including equity in all our discussions. We're doing this work in partnership with the Department of Equity and Learning, which Ami Fishman is leading, and she provided you an overview last month of their work. We're doing this through one-to-one kind of series trainings, if you will. So as each team is built, we're meeting with her to make sure that we're thinking about equity appropriately and that we're calling it out as a priority. Additionally, we want to make sure that we're improving patient care and outcomes by using data and best practices. All our QM team here is going to complete A3 Thinking class in the month of October in partnership with our colleagues at ZSFG. And so we're very excited about that. And lastly, we just want to ensure that we're constantly in a state of survey readiness. Next slide, please. And so this slide just really breaks out the 6 domains of healthcare quality. So for me, it was really important to call out these principles that were established by the Institute of Medicine. This is a big shift for the department here to ensure that we are having an intentional practice that is guided by these principles. We want to assure that we are addressing our effectiveness and safety in our care and the environment for our residents, that we are absolutely patient-centered in all the work that we're doing, and that we are equitable in the care that we're providing. Next slide, please. So this slide is just an overview of our structure. It shows our 5 new teams that we now have. We are still working to onboard a few folks, but our department now consists of data analysts, risk management, regulatory affairs, infection prevention and control, and performance improvement. We're actively working to recruit our remaining 5 vacancies, and given that the risk management team is led by one strong individual, our regulatory affairs nurses are doing double duty, if you will. But I do want to acknowledge that this is in line with their historic day-to-day work, so they absolutely can manage it, and it is very important for us to continue to be proactive in recruiting and hiring, which we are doing. And I also want to just acknowledge Troy because he has also been a strong partner in ensuring that we are working with HR to fill those positions. Next slide, please. So for the next few slides, I'm super excited because I want to introduce to you the leaders of this department and their great work. The paragraphs, if you will describe what each team does, but I'm going to take this time to highlight the person, if you don't mind. So here is Geraldine Mariano. She is the Director of Regulatory Affairs. Geraldine has nearly 30 years of experience. She has served as a registered nurse, a nurse practitioner, a nurse educator, and a risk management nurse. She has been on and off full-time, part-time with Laguna Honda since the mid-1990s, and she has dedicated her career not only to the residents, but the staff of this facility. She is very excited for her new role and actively looking for education opportunities to ensure that she supports everyone in being survey ready as we move forward. Next slide, please. Here is Mr. Charles Lamb, or Chuck, as he prefers to be called. He is our new Director of Risk Management. Chuck comes to us with nearly 25 years of experience as a registered nurse, a risk management nurse, and a patient safety nurse. Chuck actually came to us from our partners at ZSFG, so he has experience outside of the San Francisco Health Network, but it's such an asset to have him here because he can share with us his learnings from ZSFG quality management and help us build out a risk management team here. His robust knowledge of risk management and program building is going to be a tremendous benefit to us. Next slide, please. Here is Elizabeth Schindler. She is our Director of Performance Improvement. Elizabeth brings over 15 years of experience in public health practices, lean management, and healthcare administration. She has been with Laguna Honda for the past 7 years and has served in a variety of roles. And what is so wonderful about Elizabeth is her great love for process improvement and her dedication to supporting the nursing team here at Laguna Honda. Her role right before joining us was actually part of the nursing team. So she brought already to the quality management team a great relationship and rapport with our nursing leaders and frontline staff. Next slide, please. Next is our infection prevention and control team. Here is a highlight of Mr. Dr. Keith Howard. We are working to hire one more IPC RN. However, I do want to highlight Keith because he is such an asset to our team. He is certified in infection control, which is the first that we've had here at Laguna Honda Hospital. Historically, we have done reassignments for 2320s in this position who have no infection control experience. And it was so important to us to ensure that we had a seasoned person with robust experience in infection control, especially given our COVID response. Additionally, just given the sizes of our facility and the importance of ensuring safe environments. Keith brings over 27 years of healthcare experience, with the past 12 years being progressive infection control program leadership positions. So we are very fortunate to have him with us. Next slide, please. And here is our data analyst team. Lena Yu, who's currently on maternity leave, and I've been counting down till she comes back next month. She will be our lead analyst for this team. She's been with the quality management team for nearly 5 years now, and she's dedicated her work to supporting teams throughout the facility in improving data collection and transparency. And most recently, she has done a lot of work with the EPIC teams to ensure that we have EPIC reports that are available to many in the effort of improving data transparency. Next slide, please. Patient safety. We don't have someone in terms of being hired and onboarded in the quality management team, but I do want to take this opportunity to highlight Edward Gina, who you have met before. He is one of the nurse directors on our nursing leadership team, and he actually serves as the patient safety officer currently. And I'm very grateful to Ed as he continues in this role until we build out our patient safety program and onboard this position. He's been meeting with Troy and I monthly as we brainstorm and discuss how we can build out this program in a more robust fashion. So I just want to acknowledge and share gratitude for Ed in that role. Next slide, please. So some of our next steps moving forward is to onboard our new staff. Over the past 3 weeks, we've onboarded and welcomed 8 new staff, which is very exciting for us. There's a lot of new fresh eyes and experience, and you can feel it throughout the wing. We're continuing to actively recruit for our 5 remaining vacancies. And, my hope is by the end of the year, we will have those filled out so that in the new year, we can really begin to build out our work. One of the things that I've been doing in partnership with Zoe, and much gratitude to her, is thinking about how quality management can be more transparent in our communication, in our data reporting, and our communications to CDPH. We often hear that staff doesn't know what happens once they report something to CDPH, or once they do an investigation, or once they file an unusual occurrence. And my goal is to ensure we're closing the loop, and that any staff, no matter their position within the facility, can speak to the work that's being done in terms of improving patient care. So we're working to build a SharePoint page and also a quarterly communication that will come from quality management. And my big mission is to ensure accessibility of data. I want folks to be able to know what are our quality metrics, what are our health indicators saying, and why are we seeing certain feedback from CMS or CDPH. My hope is that this will help staff feel more confident and dedicated in their work, especially when surveyors come on site and ask them questions in terms of what we're doing. I also hope it will elicit feedback from staff to share with QM in terms of what they think maybe we should be focusing on, or what data questions they might have moving forward. Next slide. And that is the end of the presentation. I welcome any feedback or questions you might have.
Okay, thank you so much, Naz, for the presentation. Let me first ask if there is any public comment.
Thanks, Commissioner. Folks on the line, if you'd like to make comment on item 8, please press *3 to be recognized. Again, *3. No hands, Commissioner.
Okay, so I'll open it up to Dr. Green or Dr. Chow, if you have, Dr. Green, I see your hand first.
All I can say is, wow. I mean, how far you have come. This work is phenomenal. Just, your goals, your respect for input from everyone in the organization, everything that we've all learned in these classes about leadership and about teamwork and about inspiration for workers. And you got every single one of these here. I just remember Dr. Chow obviously was here way before me, but I remember just when I first started on the Joint Conference Committee, how much progress you've made just in this short period of time with the degree of organization, as Troy has said. I think it's so helpful to have the reports be uniform, and as the two organizations obviously are rising together, which is fantastic. I would, I just can't say enough positive about this. Just will look so forward to watching this progress and seeing everything that I know you will accomplish. There are two little things. I would love like an abbreviation thing. I have to admit, I had to look up, what was it, KPO? Luckily, it was like the third thing on the internet. But I was kind of going through, some of them you have in another slide where it's spelled out, but it would be great to know what some of the abbreviations are. And then I would love to look at a legible A3. I think these are so instructive and they help us to better understand really the detail behind your thinking. But this is really incredible, and you deserve high praise and very inspirational.
Thank you very much, Commissioner Green. We'd be happy to share with you those A3s.
That would be great for us to have that. My eyesight is not improving with age, unfortunately. Dr. Chow.
Yes. Well, today must be the day of a lot of fulfillments of things many of us have been looking for. And Troy is quite right. I think he's heard where often we had to refer, which was kind of embarrassing, to the work that you were all doing, that Troy did so much at SF General to also help improve it. So it wasn't that, it was already there 30 years ago, and over here we didn't do anything. And I think Commissioner Green is right. Both sides, both large organizations were moving, and the track is very interesting because they were moving in the same directions. I think, in fact, we have. There was a time when people were thinking that the way to do that was to merge medical staffs, and I think that this is actually far better, where each of the organizations, and also merge hospitals, but I think each of the organizations has their own very special missions that are allowed to be played out with concentration on those missions by keeping our two institutions separate, but bringing together, like you have all done, key sharing, as I think Troy put it, sharing resources and understanding. And a lot of that did come from the fact that we all saw how well Troy was actually changing General. So it isn't that. Our folks here shouldn't feel that they were inferior. Both organizations were struggling to see how best we can do quality care. And for those who kept thinking that I was really prejudiced towards the General system, it's only because they had Troy, and over here we didn't. And actually, I think this also fulfills the idea of having a functioning health network, because by escalating up to that, you will soon answer my third question, or third desire, was that the remainder of the network also come under some sort of a quality program that is unified. So really, again, kudos to you all, to Naz, to Troy, obviously to the great leadership that helps look at what we should be doing rather than trying to be protective. I mean, we all don't need silos. And I think we're beginning to see where many of these things are now interacting. between our different former silos, I will say, and that we will all feel that we're parts of a whole that I think then lends also a pride on the part of all the people who are working within the department. So I can only commend you for having achieved this, and I look forward to, and I know, you know, that this will be an extremely important progress that will really make us understand all the great work that you are all doing, and will be a process in which we'll also be able to understand our deficiencies and constantly be improving. So that's just wonderful to hear this today, and thank you very much for all the very hard work you're all doing.
Thank you so much.
Thank you. Thank you, Commissioner Chow. And the only other thing I would add is my thanks also for the accomplishment so far, in bringing really just a sense of both joy and urgency, I think, which is really interesting to be able to do, you know, to this really, really important priority for us. Really excited to see that you've been able to attract, you know, highly qualified folks to the team, that you were able to pull them from within Laguna Honda as well as from within the network, because it just goes to show that we had great people to start with. And it was really just a matter of giving folks the opportunity, in some cases, some additional training ongoing. And I really wish we were there, because it would be great to be able to meet some of the folks as we're launching the sort of joint effort around quality. And I know we'll do that soon enough, but just want to be able to on behalf of the committee, to congratulate you and congratulate the folks that have been brought onto the team, and really look forward to seeing what's possible under this sort of new structure and new collaboration. So thank you very much.
Thank you very much. I really try not to get emotional, and I just so appreciate the feedback. I feel very, very grateful and blessed to be in this role and position, and I thank all of you for trusting me to do this work.
I'll just add, I really appreciate the positive feedback, and just to reiterate what an amazing leader Naz is, and her ability to bring this group together and really build this program aligned with you know, our combined thoughts and vision around SFHN quality. It's just amazing to see this come together. And so thank you, Naz, for all your work you're doing at Laguna Honda. Very important.
You know, and before, I know this is, I think, the last item on the public agenda, but I just want to be able to say again, you know, you all have made us on the committee look really good with everything that you've been able to bring to the agenda to date. But you've also raised the bar and the expectations, so which is a good thing. But I'm really glad that we are where we are, and please, you know, to the extent that we on this committee and as the commission can do anything more to support the good work and the advances and the progress that's being made, and to understand the challenges better, right? And to really understand why there are, you know, potentially ongoing deficiencies, and the ways that those are being addressed very innovatively and very collaboratively. So I want to just be able to sort of end, you know, this portion with that comment to you all.
Thank you, everyone. Yes, and I just want to do a quick acknowledgement that there are some staff, some of the leaders that Naz mentioned have been in the meeting and waiting, and so just want to acknowledge, thank you for staying through this, and of course, thank you for all your good work. So, commissioners, the next item is item 9, and a consideration for a closed session.
So moved.
Second.
I'll do a roll call vote. Commissioner Chow,
Yes.
Commissioner Green,
Yes.
and Commissioner Guillermo.
Yes.
All right, everyone, it'll take me about 30 seconds to move this over. Folks on the line, during the closed session, you will not be able to see or hear us, but we will be back in case you want to wait. Not sure how long it'll take. Okay, we're back in open session. So commissioners, please consider a vote to disclose or not disclose discussions held in closed session.
Move not to disclose.
Second?
I'll do a roll call vote. Commissioner Green,
Yes.
Commissioner Chow,
Yes.
and Commissioner Guillermo.
Yes.
Thank you. And then we are at a consideration for adjournment.
Your motion to adjourn?
I'll move to adjourn.
I'll second it.
Commissioner Chow,
Yes.
Commissioner Green,
Yes.
and Commissioner Guillermo.
Yes.
All right, thank you, everyone. And thank you especially to Dr. Kim and Dr. Hathaway for your flexibility and during the closed session.
And thanks to you all again for an excellent meeting. Thank you.
Thank you all.